What is ICU and what are the cases do we see within the ICU? Sir, ICU is denote for the intensive care unit. It is a specialized unit which provide the special and well organized care for the patient and 24-hour surveillance. The cases which we see in the ICU are the cranial neurosurgery, head injury with airway obstruction, intubated patient including tracheostomy, chest drain patient, ventilation difficulties patient, unstable pulse and blood pressure may be high or low, different type of shock patients, hypothermia and hypoxia patients. The equipment we used in the ICU setup is the patient monitoring, respiratory and cardiac support, pain management, resuscitation equipments, and diagnostic devices. The monitoring equipments are pulse oximeter, intracranial pressure monitoring, apnea monitors. The life support and resuscitation equipments are the ventilators, infusion pump, crash chart, intra-aortic balloon pump. For diagnostic equipments, we use the ABG machine and the mobile X-rays. In the cases of dyselectrolemia, the most common dyselectrolemia we see in the hospitalized patient is the hyponatremia, which is less than 125 milliequivalent. And for this, we use the 3% saline for the management. And the hypernatremia patient, which is at the level of 158, more than 158 milliequivalent, we use the 5% dextrose. And for the hyperkalemia patient, which is more than 8 milliequivalent, we use the calcium gluconate injection. And for hyperkalemia patient with a level of more than 8 milliequivalent, which can cause diastolic arrest, we use the IV calcium gluconate. And for hypokalemia patient, which is the level of less than 2.5 milliequivalent, there be a chances of diaphragmatic paralysis. We use the calcium. We use the KCl drip. For a hyperkalemia patient, level of more than 30 mg%, which can cause a systolic arrest, we use the abandronate. And for hypocalcemia patient less than 7 mg%, which can cause laryngospasm, we use the calcium gluconate. And for the hypermagnesemia, which is more than 10 milliequivalent, which can cause asystole, we use a calcium gluconate. And for hypomagnesemia, just less than 1 milliequivalent, which can cause ventricular arrhythmia, we use the magnesium sulfate. Shock patients are also seen in the ICU setup. Shock is termed as a hypoxia at cellular level. Shock can be classified into four types: hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. Distributive shock is divided into further septic shock, neurogenic shock, and anaphylactic shock. For hypovolemic shock, there is a blood loss due to trauma, maybe internal or external. In the management of hypovolemic shock, there are four classes. First class is when there is a loss of 0 to 15%, we manage by the oral fluids. And then second class, when there is a loss of 15 to 30%, then we use the IVF crystalloid. In the third class, when it is 30 to 40% blood loss, we use the crystalloid and colloid IVF in a ratio of 3 to 1. And in the fourth class, when there is more than 40% blood loss, then we use a massive blood transfusion. Diabetic ketoacidosis patient also seen in the ICU department. It is a potential life-threatening complication of the diabetic mellitus with signs and symptoms of the vomiting, abdominal pain, tachypnea, increased urination, weakness, confusion, and loss of consciousness. Physiological factors are the infection, not taking insulin correctly, stroke, and abuse of steroids. The most common reason for the diabetic ketoacidosis is because of the shortage of insulin in the body. The body switches to the burning of the fatty acids, and which produces the acidic ketone bodies in the blood and urine. Ketoacidosis can be diagnosed by test finding of high blood sugar, low blood pH, and keto acids either in the blood or urine. For the treatment of diabetic ketoacidosis, we use the 0.9% sodium chloride, that is the fluid of choice, and the insulin drip with 25% dextrose is also used for the influx of potassium, which helps in the acidic pH level of blood. Acute respiratory distress syndrome patient also seen in the ICU. It is a type of respiratory failure which characterized by the rapid onset of the widespread inflammation of the lungs. The causes are the chemical pneumonitis, toxic gas inhalation, multiple blood transfusion, acute pancreatitis, pulmonary contusion because of the trauma, and systematic asthmaticus. The symptoms of ARDS is shortness of breath, tachypnea, and bluish discoloration of the skin. Common complication are the blood transfusion, which lead to a febrile non-hemolytic transfusion reaction, and for multiple blood transfusion, it can cause hypothermia. And death after blood transfusion is because of the transfusion-related acute lung injury, and mostly because of the fresh frozen plasma transfusion within the 24 hours. And multiple organ function failure is also seen in the ARDS patient, which involve the two or more than two organ dysfunction patient. Most common cell damage in acute respiratory distress syndrome is endothelial cells or the pulmonary vessels. And the diagnostic criteria which is used is the PaO2 and FiO2 ratio decrease less than 300. We can classify it in three bases: mild, moderate, severe. If PaO2 and FiO2 is between 200 to 300, it is mild. Between 100 to 200, it is moderate, and if it is less than 100, it is severe. For investigation, we use the ABG, in which there is PO2 is less than 60 to 100 mm, and PCO2 is more than 60, which denotes the respiratory acidosis. By chest X-ray, we can classify the ARDS reason. It can be cardiogenic or non-cardiogenic. If it is non-cardiogenic, the CT cardiothoracic ratio is normal, paracardiac area is pairing, and cardiophrenic angle is not blunt. In cardiogenic, whereas in cardiogenic pulmonary edema, there is a bad wing appearance, CT ratio increases, and there is a costophrenic angle blunting. And for the treatment, low volume ventilation with the 6 ml per kg nursing prone position is being used, and IVF with the central venous pressure is less than 2 centimeter of H2O. Respiratory failures are of four types. Type 1, in which the partial pressure of O2 is decreased and PCO2 is normal, that is hyperventilation, which is seen in the ARDS patient, fat embolism, acute asthma, pneumonia, and spontaneous pneumothorax patient. This all leads to the respiratory alkalosis in the type 1 respiratory failure. In type 2 respiratory failure, there is partial pressure of O2 decreases and partial pressure of CO2 increases that cause the hypoventilation. A 2 respiratory failure can be seen in the patient of chronic bronchitis, tension pneumothorax, status asthmaticus, obstructive sleep apnea, and foreign body in the glottis. This will lead to the respiratory acidosis in the patient. In type 3 respiratory failure, there is a post-op atelectasis, and for the management we use the O2 with chest physiotherapy, that is incentive physiotherapy, that is incentive spirometry. 2 respiratory failure is decrease in the perfusion of respiratory muscles. For the management we use the endotracheal intubation plus intermittent positive pressure ventilation. For type 1 respiratory failure, we use the low volume ventilation with a 6 ml per kg for the management, and for the type 2 respiratory failure we use the tight fitting mask ventilation, which is non-invasive ventilation, and with the aim of with the aim of decreasing the partial pressure of CO2.